Good morning, everybody. Thanks for joining us. Happy Thursday. Best wishes to everybody and their families in these really difficult times. So I just turned 50, so I've decided I'm going to no longer apologize for how fast I talk. So for everyone listening to this webinar, I know I go quick. There's a bunch of data in it. Everything I present is available on our website. And the focus of this conversation today is very much on schools, specifically how to fund schools to be healing-centered. So the title of today's talk is Financing Justice and Equity at the Nexus of Public Health and Public Education. And we're going to dig into some details. So if you're if you're not psyched for Medicaid details, this isn't the right call for you. So maybe one way to think of it is we'll be drinking from a fire hydrant in the next 45 minutes or so. And please feel free to load questions in the chat. I'm looking at them. And as they come in, I'm happy to try to answer them. I'm going to talk about a paradigm shift at the nexus of health and education, because while I'll be talking about money and how to bring new resources in to fund stuff, we can't do what we're doing. So we both have to resource newly and think newly about the work we do. And apologies for the sound of a plane in the background. I'll let it pass. Then I'll give you some data which many of you know about the social and emotional health of children in California. And I'll add a little bit of new data out just this week, which will chill you. If it wasn't bad enough, everything we anticipated happening is happening. And I'll give you some of the most recent data out this week from the CDC on emergency department utilization. We'll talk about schools as essential actors in any solution at scale. So when I speak today, I hope that for those of you from the educational community, I hope you can see that schools have a role here, not simply as handout, but the healthcare system must center schools in any response at scale. Schools must be a hand up for the healthcare system. I think it's an opportunity where the needs of both systems can be only met through centering schools in a response at scale. I'm going to teach you in about 2 minutes or less how Medicaid works. So if you're confused about how Medicaid works, that's because it's confusing on purpose. The diffuse accountability of California's Medicaid program has imprisoned us in dysfunction. And I will try to cut through the drama and details. And I will note that every single revenue stream that I will talk about today, I have either delivered services in or administered directly. So I learned these Medicaid programs by having to make payroll or by directly serving young people and families. So I'll try to distill that for you. I'll talk about the 5 models that schools use to access the 7 different payers that represent Medicaid in California. I'll talk about not only how philanthropy can engage, but how we can all engage. And I'll also talk about the places where these conversations are happening. Because if, like me, that we're having a little bit of death by task force, and I'd like to talk a little bit about how to focus our energy as a movement on particular tables. So if you take nothing else from what I say today, there are financing opportunities. There is an opportunity, even in these difficult budget circumstances, to do something at scale in schools, but this will require us to think differently. We'll have to reform both our conception of what schools do and how they behave, and how the health system funds and supports this. So we have to reform Medicaid, and for those of you who have heard me talk before, symbolized in this simple concept that we must remove diagnosis as a prerequisite for care. Mental health, behavioral health, developmental health should not be considered a response to pathology. It should be a support for healthy development. And I'll explain how that is actually consistent with the Medicaid statute as conceived in 1967. For those of you who don't know, in the decade before COVID, we were in the midst of a behavioral health crisis. And this is before we disconnected children from their schools and their peers. Between 2000 and 2017, we'd seen a 104% increase in inpatient visits for suicidal ideation and self-injury, while the rest of our healthcare system saw a decrease in bed days, We saw a 50% increase in hospital days for children between 2006 and 2014. We asked kids, and they told us that this is California Healthy Kids Survey data. Young people have self-reported a 61% increase in need, and just one of many indicators of our system's deeply challenged performance. We're 43rd in the nation in screening. If you look at the Commonwealth Fund or Mental Health America's most recent analysis, we actually are 44th in the nation in mental health access for kids. So this data can demean and diminish the human suffering behind it. So the reason we show this data is before COVID hit, we were in the midst of an epidemiological crisis. Now we are in whatever happens when a crisis goes unaddressed and is dramatically exacerbated. But we actually have a solution at our disposal. More than half of all the children in California are enrolled in Medi-Cal, California's version of Medicaid. There's actually been a 30% increase in enrollment over the last 5 years. For the policy wonks who are listening in, you may ask, what has driven this enrollment? Well, first, and maybe foremost, California is ground zero for income inequality. 7 out of 10 children born into poverty never get out. But also in California, we rolled our SCHIP program, our Healthy Families program, into Medicaid. And we did a lot of really good work under the Affordable Care Act that brought in eligible but unenrolled family members. Finally, in 2016, we added the undocumented children through the previous SB 75. So please, there's 2 SB 75s, the one you've heard about at Breaking Barriers, but also the previous SB 75, which in a great act of social justice added undocumented children to the Medicaid full scope benefit. So where we're at is 96% of all children in the state are now covered by a health insurance product that includes a defined behavioral health benefit. So we actually envision that within the next couple months, 6 out of 10 kids will be covered by Medi-Cal, with about 4 million commercially insured. And we're not leaving out the commercially insured. There's lots of action happening. SB 855 passed, which should finally give us the tool to enforce the 2008 Federal Parity Act in California. So all children are worthy. A comprehensive program that centers schools in a response at scale must be able to bill both commercial insurance and Medicaid. But Medicaid is an essential opportunity for us because of our historical failure at doing it well and some of the financial drivers I'll speak to in a second. And as our amazing Surgeon General is telling us, COVID is exacerbating it all. It's exacerbating the equity gap. It's creating a massive disruption in children's routines. It's creating economic security and isolation, which we know increases the risk of intimate partner violence and drives behavioral health utilization across our system. We've measured this in every other economic downturn in our state's history. And incredibly, it has destabilized our provider network. I was just talking to Richard before I got on about the extraordinary success of the children's community health organizations in converting so much of the existing EPSTT services to telehealth and telemedicine, and how there's essential elements of that conversion that must be sustained and expanded upon even after these dark times are over. But providers have become incredibly creative at finding ways to reach out to families and children who are already engaged in care. But lest we over-celebrate this, when you close schools, you disconnect almost half of the children's mental health system. From the IDEA-funded services to the EPSTT outpatient services to the other social and emotional supports, schools are ground zero for the youth mental health crisis, and they are the essential actor at scale. So the destabilization of the provider network is seriously going to impact our ability to scale, even if we get the finances that I'm about to dig into right. I mentioned the data that just came out this week. For those of you who need the data to tell you what you know is happening, if you do a comparison between the 7 months in COVID and the 7 months previously, 2019 to 2020, you will see a dramatic increase in mental health related emergency department visits for children 5 to 11 and 12 to 17, a 24% increase for children 5 to 11. And this is extraordinary. Kids 5 to 11 very, very rarely go to the emergency department. I worked in the level 1 pediatric trauma center at Oakland, Children's Hospital Oakland. We very, very rarely received children 5 to 11 for mental health crisis. That number is dramatically expanding. And maybe just as importantly, These visits are not billed as mental health visits, they're billed as medical visits. No health plan budgets for 5 to 11-year-olds going to the emergency department. So this is what we call a cat killer in the industry, meaning it's going to suck dollars out of health plans and force them to respond. The 12 to 17-year-olds is part of a trend we've seen of increasing utilization of crisis services at a younger and younger age. And we could spend the rest of this webinar talking about why. What happened in around 2005, 2006? Why did twice as many of our children start to hurt themselves in such a way that they needed to be admitted to the hospital? Was it 400 years of structural racism? Was it 2009 when social media apps became available on mobile platforms? Was it our historical failure to provide adequate funding for Medicaid? Was it our narrow definition of mental health in a strict medical model that did not reflect the needs of young people? The answer is it's all of these things. And what we now know is our health system is failing to meet the needs of young people in its current construction. It must be redesigned. The final data point here is that 1 in 4 young people ages 8 to 24 have seriously considered suicide before the pandemic. Since the pandemic began. You can't look at this data without disaggregating by race. And there is a legitimate question we must all ask ourselves is, can Medicaid become a tool for anti-racism? We at the Trust believe it must be. It must become a payer for social justice. It must become openly and overtly anti-racist because 81% of the 5 million plus kids in the Medicaid program are non-white. And children of color experience behavioral health challenges at dramatically different rates, not only suggesting, but proving that being poor and brown and Black in our culture is life-threatening. The suicide rate for Black children ages 5 to 12 is twice that of their white peers. And for any of us who've spent time working in juvenile justice settings, we know that the juvenile justice system is simply a placement system of last resort for children with serious behavioral health concerns. Making schools healing-centered means we can't just take this failed system and drop it into schools. So sometimes when I talk, I very appropriately get feedback from people listening saying, hey, Alex, it's not just about more therapists, or it's not just about more money. And that is such the right response to what I'm saying. Yes, we need more therapists. Yes, we need more direct clinical services, but we also must reconstruct our benefit so that peer-based programs, that parent partners, that social models, that programs that support the social and emotional health of children that do not require a clinical intermediary become not only an expected, but institutionalized component of our Medicaid program. So while eligibility for mental health services has increased, right, that 20 to 30% increase, in 2010, 2011, there was 4.2 million EPSDT eligible kids. In 2017-18, there was 5.8 million. It's declined a little bit to 5.2 million, but now growing again because of the economic impact of COVID. Less than 5% of those kids are getting access to any care at all, and less than 3% are in ongoing care. These are horrendous numbers. This represents a collective failure. And of course, I don't mean to say, oh, this person did it wrong. I don't believe there's bad people. But we together have not done right by the young people in our culture. And despite our progressive public narrative, when you peel back the onion or pull back the curtain, California is showing how little it values its young people through how little they get, despite these striking increases in utilization and acuity. As I mentioned, we project a 20% increase in enrollment by fall 2021. We legitimately think that most schools could see 7 out of 10 children enrolled in their school being eligible for Medicaid when school returns post-COVID. So there may be people listening in today who are either educators or have worked in schools and have thought about this issue in the past and have looked at various Medicaid strategies and thought, the juice isn't worth the squeeze. And boy, do I get that. Like, I have run those spreadsheets and they do suck, and it is really hard. But for a couple different reasons, I would ask us all to set aside our past conceptions and re-examine the opportunity that Medi-Cal represents as a way to generate resources to fund healing-centered schools. The first is the dramatic increase in enrollment. The second is the universal acceptance that what's happening isn't sufficient. And the third is a political will and new leadership at the state that is unique. I have been doing this work for 20 plus years. We have leaders who legitimately believe this is a critical issue, who have demonstrated efficacy. When Will Lightbourne ran child welfare, our state got to a 60 or 70% penetration rate for kids in child welfare. Mark Galley is a pediatrician who I know believes in this issue. Kelly Pfeiffer is a primary care pediatrician who very ably led the San Francisco Health Plan's extraordinary success in standing up the mild to moderate benefit. We have leaders who believe in this work. Now, they don't have a magic wand. They can't make it right simply because they're good people. We have to work with them together to suggest alternatives and opportunities, which I really do believe are out there. So a little bit more piling on, and if you're not depressed, you're not listening, but a couple more data points, because this is a segue to solution. Please stick with me. We rank in the bottom third nationally in spending per kid. Children represent 42% of all enrollees, but only 14% of all expenditures. So for those of you listening to some of the talks we've been doing on the managed care plans, we think there's a future state where health plans, remember, not the mental health plans, but the managed care organizations, the physical health plans who now have the mild to moderate benefit, we think that there is a future state where they can fund a whole lot more under both the mild to moderate mental health benefit, but also under care coordination and case management. And the April 2019 audit is off-cited, but it's no secret or no history that the children's Medicaid program in California is struggling. The more recent data analysis that I think is probably most cogent is the Commonwealth Fund and the Mental Health America both put out their 2020 analysis, state-by-state comparison, and both ranked independently California 44th in the nation in mental health access for children. So schools can and must be essential actors in our response at scale. Those of you who are on this call who work in schools know that they're ground zero. And as I mentioned, the healthcare system needs schools. First, children 8 to 18 have the lowest rate of primary care utilization of any demographic in the Medicaid program. Now you may ask, why is that so important? Well, the healthcare system in the managed care paradigm relies on the primary care physician as the gatekeeper and referral for care. So if kids don't go to primary care, how are they supposed to connect to the broader healthcare system? Schools simply must become the central place and point of first contact for a reformed mental health system. Not only because kids don't go to primary care, so there's no referral to be made, but second, because those of us who've worked in adolescent health know that if you want to kill volumes in a mental health clinic or in any kind of mental health initiative, put police or parents in the waiting room. Meaning there's a process during young adulthood where you individuate. That term individuation comes from Erik Erikson. It refers to the process of a young person developing a sense of self independent of their primary care group. And this process is natural and appropriate. Schools have that opportunity to meet young people where they are and help them develop that sense of self and efficacy and understand the pressures, the unique pressures that this culture is creating on their healthy growth and development. And if you don't remember any of the other data I presented to date, the message I'm providing is it is different now. It is harder to be a kid in this culture than at any time in the history of our culture. In the last 20 years, suicide leapfrogged cancer and car accidents as a cause of death. For low-income children, the two leading causes of death are homicide and suicide. Schools must be the place that greet young people, help them understand the context they live in, teach them about structural racism, and help them understand its impact on their social and emotional health and well-being. But maybe just as importantly, and while it's not about the money, I often say to people who say to me, it's not just about the money, Alex. I say to them, either you haven't run a safety net system or you've never been poor. Because the fundamental characteristic of safety net systems in California is they're under-resourced. I just showed you how little we spend per kid. One way to think of California's Medicaid program, again known as Medi-Cal, is think of it like a shriveled Charlie Brown Christmas tree. ranking 44th in the nation in spending, with a bunch of beautiful Christmas tree ornaments hung on it. We are serial entrepreneurs in California in the social safety net. We pass propositions that claim to solve all of our state's ills. Prop 10, Prop 63, Prop 64. All of those dollars are essential non-federal dollars that could be matched to Medicaid, but we don't do it. So we're shooting ourselves in the foot. We tax ourselves at the 4th highest level in the nation and spend in the bottom third. So as I'll teach you in a second, that's a symbol of our stupidity. Until we unfragment ourselves and open up our hearts and minds about how we spend money in this state, we will never fund a solution at scale. So here we go. I'm going to teach you Medicaid, the children's Medicaid system, in 2 slides and 4 minutes. So take a deep breath. I'll do it too, because I know I'm talking fast. All of Medicaid works this way. One way to think of Medicaid is like it's a pot of gold sitting in Washington, D.C. You get $1 if you put up $1 and follow the rules. Every Medicaid expenditure is part federal, part state or local. That state dollar is called a CPE, otherwise known as a certified public expenditure. Think of CPEs as a non-federal dollar, a public non-federal dollar that's not already being used to match a federal dollar. You can't match it twice. So think of a CPE as a clean dollar. That federal bucket of gold is called federal financial participation. Together, this state or local dollar, a CPE, and this federal dollar, FFP, together they equal a Medicaid expenditure. What makes children unique is that the federal match is guaranteed. So I need to give you all the briefest of history lessons. And a very famous paper is available on our website called The National Security Origins of EPSDT. And we have 2 papers coming out in the next 4 weeks that track both the national and state context for EPSDT in California. But for those of you who don't know, in 1965, the Social Security Act passed. Under Title 19 of the Social Security Act, we created Medicaid, known in California as Medi-Cal, and Medicare. Medicaid for low-income populations, Medicare for the elderly. In 1967, just 2 years after the passage of the Social Security Act, the military sponsored an amendment to the Social Security Act. And it did so because they had just finished drafting hundreds of thousands of young men for the Vietnam War, and they had rejected half of them for unfitness to serve. The military was so freaked out by the health of low-income children that it sponsored an amendment to the Social Security Act saying, children need stuff that adults don't need. We need to invest proactively in their health and development so that they can grow up to be 18. Now, they wanted them to grow up to be 18 so they could serve in the Army. But the premise was that low-income children were facing such massive challenges that we needed to think of Medicaid differently for them than for adults. So that amendment changed the definition of medical necessity, meaning who qualifies, and it created an uncapped federal entitlement, meaning every dollar a state puts up has to be matched. So for those of you who have financial brains, you're probably thinking about the opportunity that I'm proposing. We're spending the money in California, we're just not matching it. We think that we can fund an expansion at scale in schools simply by matching the dollars we're already spending if we unclog the plumbing. Just to finish the history lesson, that set of benefits that was initially created in the amendment to the Social Security Act, you know as EPSDT. And perhaps the most famous of those benefits is the most successful experiment in the history of our nation's public health system, which is immunizations. Super pressing issue for us in the current context. Young people in Medicaid get immunizations about 80% of the time. They don't have to be sick to get them. They get them because we've made a decision as a Medicaid program that paying for those immunizations, like measles, mumps, and rubella, are essential to their health and welfare, and you don't have to be sick to get them. The simple crosswalk we are suggesting is that we reinvent mental health consistent with the EPSDT entitlement. You should not have to have a diagnosis to get access to mental health, the same way you don't have to have measles to get an immunization when you're a little kid. So let's talk about how this actually shows up in the lives of kids, because what I'll do in a second is talk about how schools can access these resources. And if you don't know, everything I'm about to go into is in a guide we produced about 6 weeks ago called The Practical Guide for Financing Mental Health in Schools. I'm giving you a distilled version of it. I highly recommend you read it. It's been downloaded and distributed over many thousands of times in just the 6 weeks we've created it. There's a real thirst for it. But remember how I said there was this FFP? It gets matched through the CPE. The state puts up $1, it pulls down that FFP. How does it show up in the lives of kids and families? And this story that I'm about to tell you is probably the biggest reason it doesn't work, is we've diffused responsibility across so many actors that it's hard to know who's even responsible for what in our system. The first and biggest way that these matched dollars flow to children and families is through the managed care plans. And for those of you listening in today, this is one of the greatest opportunities before us. Managed care plans, meaning the health plans that serve about 85% of all children in the state. 85% of all kids in the state are enrolled in a Medi-Cal managed care plan. Think of that like a health plan, the same way you and me have a health plan like a card. And there are public plans and there's private plans, and each county has a different economy of Medi-Cal managed care. We did a training earlier this week with the Alliance where we did a Medi-Cal Managed Care 101, where we described the history of managed care in California and the context in each of the counties. You can go to our website to click on that 101 piece. But what's really important is the managed care plans are increasingly active in children's mental health. In 2014, they were given the mild to moderate benefit, and there was very little, if any, utilization of that benefit in 2014. But between then and today, utilization of that benefit has increased by over 100,000 unique children. During that same period of time, the specialty mental health system grew very little, if at all. So managed care plans represent a huge opportunity for us who are looking at reform. They're where the deepest pockets are, and they're where the least is happening. That's a good mix. The second largest way that funds flow to the lives of children and families for social and emotional support, i.e. behavioral health, is through the county mental health plans. It is important to note that county mental health plans are actually health plans under federal law. They are called prepaid inpatient health plans. If you look in the bubble here, I note the methodology that is used for funding. The MCOs get paid in capitation. That's called per member per month. Think of it like an umbrella. You take in a monthly payment for everyone in your plan, and you use the money to pay for the people who are sick. That couldn't be more different than how county mental health plans are funded. They are funded under something called certified public expenditure, which means they get some money from the state, 3 big sources. They collect whatever they can locally, they spend it, and then per minute, per kid, per diagnosis, they pull down a federal match. And if that sounds complicated to you, it is. I have run Medicaid financing strategies in hospitals, in ambulances, in primary care, in specialty care. About every way that Medicaid flows, I've been involved in financing and administration. By far, the most complex and administratively burdensome Medicaid transaction in California's safety net is the behavioral health cost report. And it's not even close. It is extremely complex. In fact, I would argue there's only a handful of people statewide who could be considered truly expert in it, and it simply must be changed. And you all know this because you hear from providers and even county mental health plans that we spend 30 to 40% of our time administering the program instead of serving kids. There are other critical Medicaid programs that it's important for those of you interested in schools to know about. The school districts have their own program. You've heard earlier at Breaking Barriers about the SB 75 work that WestEd is really very ably leading. I want to make sure that I acknowledge an extraordinarily difficult task that WestEd has taken on in pulling together a really diverse group of stakeholders. And I think they're doing an excellent job And I think the recommendations that come out of that work group are going to be excellent. But schools have their own direct billing mechanism. It's called the LEA program. There's both a direct billing option program, BOP, and an administrative activities claim. There's two sides of it. Through the extraordinary work of some people who may be listening in today, we had nothing to do with it. A state plan amendment was finally approved. So congrats to the California Teachers Association, to the school nurses, to many others who got the state plan amendment approved. That this state plan amendment expands the eligible services and the eligible providers. This should allow school districts to jump on board and expand their Medicaid revenue. There are issues, so I want to be kind of temper expectations here. Total billing annually in LEA BOP is $149 million a year across all schools in the state. Only half of the school districts in the state even participate in the program. So if we are extraordinarily successful, we will grow LEA billing $100 million over the next couple of years. And that's a legitimate target. And we should go get every 100 million matters. But I am suggesting that what we need, the type of investment we need in schools, should be measured in Bs, in billions, not in millions. So the LEA program is an important component of the solution, but it is not going to be the answer. And I'll talk about some of the swing for the fences ideas I have at the end of the presentation. Community health centers also have their own billing mechanism called the wraparound rate, or PPS. Public health departments, through a program called CMA and targeted case management, can bill directly, as can the regional center. I can't even see my point here, and public hospitals. But really, if you're a school, someone interested in schools, these first four are the essential ones, and I put in light blue the county ones just because I'm an old county guy and I kind of believe there's more to be done there. But if you're thinking about schools and how they access Medicaid, and as you'll see in a second, I'll take you through how schools are doing it now, because there's no right way, everybody. We got to stop kind of being too invested in trying to win which model is best argument. The model that is best is the model that works. So what I would suggest to everybody is let's stop beating each other up over which is right and which is wrong, and start trying to support each other in saying which is the best way to get more as soon as possible. So in our practical guide, we describe Medicaid, we break down how it works, and then we dip into how schools are interacting with these 4, sometimes 5 payers. Because if you're an educator, I think you have to place yourself on the map. There's so much conversation about this topic that before you can decide how to proceed, I think you need to understand where you are. In therapy, we sometimes say the journey out is the journey in. So we begin with reflection. So what we tried to do in the practical guide is name the ways that schools are currently tapping these 7 payers, really 4 payers. And I'm going to take you through them now, just to give you our take on how it is. So these 5 models are, first, some of the big school districts do it themselves. They bill BOP direct, they get credentialed and become under contract with their local mental health plan. Some are even exploring contracts with their managed care organizations. I would say this is a heavy lift. The more sophisticated districts do it. I think for many districts, this is not a path we would recommend, though for the districts willing to take on the indirect cost of building their administrative systems, it's certainly doable. So this happens in some of the bigger school districts. And by the way, I need to say, none of these models are mutually exclusive. The reality is that most districts use a combination of them, but each one of them has a different prescription for action. So determining how to proceed means placing yourself in the current context of these 5 models, and then choosing the strategies specific to each one to grow them. SELPAs, particularly the extraordinary work that Ron Powell led at Desert Valley, but also some work that's going down in San Mateo. SELPAs also play this role where they play kind of an intermediary function and provide services in schools. The dominant modality is community-based organizations like a Seneca or a Hathaway Sycamores, or like a Children's Institute or a Victor Treatment Centers. These are community-based mental health providers who execute a contract with their local county mental health plan and get located on schools under some form of collaborative relationship, either in a dedicated special education setting, like a counseling or classroom, or sometimes in an outpatient treatment model, just co-located therapists in schools. This represents between 60 and 70% of all Medicaid revenue in schools, so it's the dominant modality. And in this model, schools pass off the administrative and personnel burden to partners in community-based organizations who have existing relationships with schools. There are real challenges here. It's not just like, oh, you check a box and you're done as a school. Coordination of service, HIPAA, FERPA, collaborative relationships, the inevitable tensions that arise when someone who works for somebody works in a place that their boss is somebody else. There's lots of challenges to this, but this is the dominant modality. There are some counties, Monterey and Alameda County happens to be the one I was raised and born in, both as a provider. And I should say, my career began as a 20-something working in the Oakland Public Schools as a therapist, where I worked with the county, started an FQHC at McClymonds High School in West Oakland. In my county at the time, I worked through the County Health Authority. This is true in Monterey. There's only a handful of counties that are using this model, but we describe it in the guide. What's really happening is increasingly county offices of education, particularly Fresno and Sacramento, are doing extraordinary work, basically standing themselves up as an intermediary between themselves, between the payers, the 7 payers, but really the 4 payers, and all of the schools in their catchment area. And Fresno has placed over 100 therapists in schools. Sacramento has an extraordinarily progressive and interesting fiscal model that they're pursuing. And there are other county offices of ed, including Santa Clara, Contra Costa, many others, who are looking at this model as a way to help disseminate access to direct services in schools. So I'm going to go through each one just because we have time. I won't take too long, but just give you a little flavor of each one and give you an example if you want to know more. And I would also suggest, again, you go into the guide. There's much more on each one of these in the guide. In the LEA model, a school district can bill largely the county mental health plan directly or their own LEA program. I list here on the left-hand side, and I'm trying to keep the bubble themes going, so sorry for my graphic design skills here, but basically the premise here is that the 2 primary revenue sources that schools who go it alone bill is they become vendorized with their county mental health department, or they bill the LEA program themselves. In this case, LEAs can and often do hire their own clinical staff. This requires a ability to develop an audit file to withstand the rigors of EPSDT paperwork, usually 30 to 40 page opening episodes, and some pretty rigid diagnostic criteria to get into care. So this is a burden, but LEAs, some LEAs, and examples that I like to give here, LAUSD does it probably the best in the state. The SELPA model, this is Desert Mountain and San Mateo. They generally, again, target BOP and county mental health departments. A lot of this is a historical remnant of the AB 3632 days. And I don't want to rehash this fight. I think I was the only health director in the state at the time who didn't want to see the end of AB 3632, not because I thought it was a good program, but because I thought shifting the IDEA obligation to schools without obligating the Medicaid system in any way was going to be a recipe for spiraling costs. And very unfortunately, I've been right. The total spend on 772,000 children in special ed will be almost $15 billion this year. Less and less year to year is being cost shifted to Medicaid. This is a fundamental problem. We must reestablish a direct line to Medicaid reimbursement that includes not just the federal share. So remember, in the LEA program, when you bill directly, the schools must provide that CPE. They only get half the money. So the BOP program is not nearly as good from a reimbursement perspective as the other Medicaid programs. So we're going to have to go back to the drawing board and re-examine the way we finance special ed in this state. And I know people are probably, throwing up in their mouth a little bit and think that's like sticking a hot fork in your eye. But yeah, we got to revisit it. We are dumping costs on the IDEA mandate in ways that is not sustainable and not fair to schools and school leadership. The CBO model is the dominant modality. In this modality, a provider like a Lincoln or a Seneca or a Fred Finch or a Hathaway Sycamores or a Children's Institute establishes a contract with their mental health plan, and they largely bill that mental health plan under what's called EPSDT, Specialty Mental Health Services. And as the quickest of history lessons here, before 2011, the matching ratio of those services was really good for counties. If you put up 10 cents, you got 40 cents from the state and 50 cents from the feds. So in my county, we put up a lot of master tobacco settlement money, tobacco dollars, and pulled down 90 cents for every 10 cents we put up. So I would call that the golden era of EPSDT. Between the early 2000s and around 2011, 2012, you saw dramatic expansion. 2011 realignment capped that state share, meaning that counties, if they wanted to expand the program, had to fund 50 cents instead of 10 cents. This created a dramatically slower expansion of services, and we can chop it up all day long about whether counties were getting enough or not enough. There's a lot of debate going on there. But obviously, 2011 realignment is basically a marker for us all to look back at the time in which EPSDT, Specialty Mental Health Services, stopped expanding at a rate that they should have. In this case, community-based organizations establish school site-specific programs. Sometimes there's multiple providers on site. I'm not the biggest fan of that. I really think that a provider should join a school community, and that the fewer providers we have on site, the easier the collaborative challenge is going to be. So anyway, CBOs get co-located. And sometimes these community-based organizations are federally qualified health centers. There's about 300 of them statewide. And they can build managed care plans directly, and they can even build managed care plans for mental health services using something called the FQHC carve-out. Anybody who wants to play around in that space, we can talk about it on the side. The county health authority model is Alameda County and Monterey County. This is an example where we're tapping at least 3 and increasingly a 4th of the 7 bubbles that I mentioned. In this case, the county health agency acts as both the payer and the intermediary, usually providing some form of professional development, technical assistance, collaborative competence, often an evaluation as well. Districts can and do partner with their county health departments in other ways. So sometimes there's pre-existing relationships like school nursing or the immunizations program or vision programs. So sometimes it's easier to build a partnership this way because the health authority already has a partnership with schools on the physical health side. And again, the 2 biggest examples are Alameda County and Monterey County. And finally, I just want to talk about the County Office of Education because I've been increasingly impressed and surprised with their growing willingness and sophistication to dig into the details of the Medicaid program and frankly, establish new and creative ways. 25 years in, it takes a little bit to surprise me. And the county offices are surprising me with their skill and wisdom and entrepreneurial spirit. There's really no way to learn this except by doing it. You got to dig in, you got to go for it. You sometimes got to risk capital, meaning put some money up, be prepared to lose it to stand up the program, to get the revenue running. And that's happening in Sacramento County, and it's happened in Fresno with some support from the mental health plan with MHSA. So county offices of ed are acting as both the intermediary and the provider, meaning they're hiring staff directly and then co-locating them out in schools. They are establishing relationships with the managed care plans themselves, which means tapping the new mild to moderate benefit and sometimes the FQHC enhancement. They're partnering with county mental health plans to build EPSDT, Specialty Mental Health Services. They are sometimes building administrative activities and the billing option program. And this FQHC partnership that is being piloted in some of the county offices of ed is a really interesting enhancement that is well worth tracking because if it works, it's going to be a way to scale programs in a new way. So I'm going to ask for one more deep breath for myself and for everybody else. We're in the home stretch here. The trust was formed. And by the way, the California Children's Trust is an initiative, not an organization. We initially had a 5-year life cycle. We're now 6 because of the Cal-Aim punt. We were created to take advantage of what we consider to be a generational opportunity. There was political will, a new administration, the leadership I referenced, a governor who believed in this work. There was also a fundamental opportunity with the timing out of the waivers to re-examine the work. There was a growing acceptance of the impacts of race and class on the health and welfare of children, from the adversity movement to the social determinants of health. There was community support. The California Healthcare Foundation surveyed our state, and more than half of Californians said this is the issue that matters most to them. And this emerging consensus is really important because we can't do this work in the medical model. This just won't fly. Like, we can't get there from here if we diagnose every kid and require 50-minute sessions. So it was the combination of these factors, the waivers, the universal acceptance that we failed, the emerging consensus that race mattered, the financing opportunities related to our high tax burden with our low federal matching funds. But to take advantage of this moment, we have to embrace the need to re-examine both systems. Like, it's not just one helping the other. Both must redefine not only their sense of self, who we are as a system, but their interaction with each other, which means putting down some past hurts. There is a lot of water under the bridge between educators and the Medicaid system, and for good reason. Kids haven't gotten what they needed, and there's a lot of blame to go around. We do need to set aside some of that and move forward in a place of healing and hope, because the opportunity to do something at scale really is before us. So if we can adopt this aligned paradigm shift, here's some of the things we could do. The first thing is we need to support technical assistance and capacity building efforts. We're going to engage in some of this, maybe just for a time delineated period of time, but the state needs to make a permanent and ongoing investment in teaching education Medicaid. You can't outsource it. We've seen what happens when you outsource it. And by that, I mean when school districts hire Paradigm and Maximus and PCG and the other sharks of the Medicaid program under school-based MA, you hire someone to do it for you, they get paid a percentage, you never learn it, and you don't really care how much money they give you. That's got to go away. Schools and school leaders need to understand Medicaid, not necessarily because they have to do it, but because they have to advocate around it. So let's call this good trouble. We need to raise the sophistication of schools and schools leaders to advocate at the Medicaid system. Some of the most progressive and compassionate school leaders I know spend scarce LCFF hiring therapists. And every time they do that, I go like, oh no, please don't. What would be better is if you called your mental health director and the CEO of your managed care program every day for 9 months until they gave you what you needed, because they're getting the money to do what your kids need. You have what they need, access to young people. So we need to teach schools how to advocate and how to interact with these systems. We need to fund systems change efforts like what we're doing, like Breaking Barriers, like the Trust. There's so many others. In fact, I see so much alignment on this topic, and I see a willingness and receptivity from the state. Like, if we can't get this done in this 12 to 24 month period, particularly in the context of COVID, then we all got to quit and go get new jobs, because the opportunity is before us. There is collective will and there's a financing opportunity. We just can't settle for incremental change. What I might suggest is let's gratefully accept incremental change and pursue it while we foment the revolution. And the revolution is a multi-billion-dollar investment that redefines the benefit as a support for healthy development and a tool for social justice. We have to incentivize cross-sector collaborations and host convenings like this one, like the work Richard is doing under 2083. What I have found in public systems is that leaders grow, they thrive, they learn the system, and then they leave, and the institutional memory is gone. So I think the biggest and most important role the state can play is to hold the institutional memory. Everything is hyper-local. It happens at the state and county level, at the county and jurisdictional level. So those leaders must be supported and taught, and we have to be prepared for their inevitable movement. We can fund timely programmatic and professional development opportunities, meaning give money in small ways so people can take time out from their work to learn this. The state can act as a knowledge worker, as I just said, and we need to provide some risk capital to try some new stuff, maybe even incentivizing managed care plans to fund care coordination and case management in school sites. So where is this conversation happening? Obviously, SB 75 is a big one. Please watch the LEA SPA. What I like to say is the SPA is kind of the short-term thing for folks to watch. The joke I make is like when you come to me and say, if I'm your therapist and you say to me, hey, I need some help, the first question I don't ask you is tell me about your mama, even though it probably is about your mama. Like, I help you meet your presenting problems first. And I think the LEA SPA is like a presenting problem. Schools are really struggling. They're facing dramatic fiscal challenges. We all should meet their presenting problems first. Give them help for what they need help for, which is getting money and building services. But the real solution at scale is going to come through the MCOs and the MHPs. So while this is a critical, important thing to do, I don't think it's the end all be all. Also, I need to add that the state just formally, for the first time ever in July, changed the definition of medical necessity for the managed care organizations under the family therapy benefit. We should do a separate webinar on this. It was an extraordinarily important and fascinating process. For the first time in our state's history, under the family therapy benefit, you don't have to have a diagnosis to qualify, and you can get ongoing care if you qualify for risk factors as determined by an expanded definition of ACEs. Here's some more reform efforts to track. And by the way, these slides, of course, will be posted on the Breaking Barriers website. So let me wrap in my last 5 minutes by framing this question. What will we do as a culture when we wake up one day and realize that twice as many of our children are killing themselves? With the support of over 400 organizations, the Trust has developed this framework for solutions. All of our work ties back to this simple construct that if you don't center anti-racism and justice, meaning if you don't acknowledge the impact of race and class on the social and emotional health of children, you aren't doing the work. Our Medicaid program must formally and directly acknowledge the impact of structural racism and the stabilization of poverty, and it must fund and reimburse services that help young people manage and understand these forces and their impact on their health and development. But even once we center race and equity, we must spend a lot more money. Like, there's no way to get around it. We ain't spending enough. So we must maximize the federal funds, bottom left-hand corner. And then as we get this new money, we must redefine the benefit by expanding who is eligible, remove diagnosis, expanding the provider class so that peers, social models, parent partners, and credible messengers can bill Medicaid. And we must increase the agency of the beneficiary in accessing care. Kids and families should get access to mental health support, not because a teacher told them they had to, or a probation officer told them it was a function of their probation, but because they want it. Their desires and needs should be the number one predeterminant of medical necessity, not the definition of a trained professional who all too often doesn't reflect their cultural and socioeconomic background. And finally, we have to increase transparency and accountability. The 7 different payers who all have a piece of the EPSDT entitlement, one of the most important things that we are asking the state to do is clarify who pays for what, when, and where, and quit the referral game or the "it's not my kid" drama that happens in every county safety net. So I'm going to end with a little bit of stirring the pot. So I call these the big 3, and this is the first time we've ever produced them in a slide deck, so heads up. Here's the 3 things that I think we should do. So I'm going to go for it. The first is we think we should increase the role in, this is the 3 things we think Medicaid should do to fund and expand services and supports in culturally relevant ways in schools. The first thing we should do is get the health plans to pay for stuff. So we should increase the role and function of the managed care plans and school-based services. This means that DMHC and DHCS should direct plans to invest in schools when certain criteria are met. If you have 100 beneficiaries in a school, you should have to place a physician, a clinician, or ensure access for those kids in or near their school. One way to do this would be establish schools as essential community providers. Another thing we can do is look at reprocurement that's coming up. For the first time in 17 years, we're putting these contracts out to bid. We could formally require in reprocurement that MCOs develop care coordination and case management contracts with schools for kids who show risk factors, including a positive ACEs screen. The second thing we need to do is accept the limitations of the LEA, BOP, and SMOP program. So we should go for that 100 million, let's go get it. But we should also build a supplemental payment program. Supplemental payment program is the name of something we do in the Medicaid program when Medicaid reimbursement is insufficient to the cost of delivering care. We do it in hospitals, we do it for ambulances, we do it for FQHCs. So basically what you do is you say, Medicaid, if something costs $100, but Medicaid only paid you 50, you develop a way to claim a federal match on the unreimbursed cost of that service, the $50 that was unreimbursed. And while this may sound fancy, it's actually common practice in the Medicaid program. This is what the reimbursable advance is called, the hospital fee program. This is what the PPS program is under FQHCs. This is what the private hospital supplemental fund is. We have to formally acknowledge that schools are an actor in the Medicaid program, and what we're paying them is not sufficient, and we must develop a single mechanism to make up for it. I will call that a supplemental payment program. And then finally, we have to reform EPSDT, especially mental health, to make it more accessible and less administratively burdensome. And we must develop it in a way that allows us, which is the second bullet point here, to claim against existing expenditures in other child serving systems. This is the essential component of the IGT proposal we made to the state during the previous CalAIM work. It didn't quite work out that way. So to be fair, we had some real concerns with how the state interpreted our IGT proposal. So we're looking forward to digging back in. All right, I just talked at you for like 45 minutes, so maybe 50. So thank you so much for listening. For much more, you can go to us at the California Children's Trust. We've got thousands of people reading our emails every month. So thank you all for helping us build a movement. And for the many of you on this call who help support our launch, we're doing it. We haven't won yet, but we're making real progress. Thank you.
Alex, on behalf of Breaking Barriers, we're deeply appreciative of your wisdom and expertise and the passion that's reflected in your work and that of the Children's Trust. Big appreciation from everybody here. If you're in participant mode, feel free. We're going to end here, and then you've got a couple minutes to transition over to hear our last session of the day with Senator Richard Pan. So we'll hope to see you there in just a moment.